Hello everyone. Thanks for joining me today, and sorry for the late notice for the talk today. So today we're going to talk about comprehensive understanding of prosthetic valves. I will start with prosthetic aortic valve, and then if we have time, we will also go into the mechanical valve today. Okay. So let's say someone have severe valvular heart disease. Okay. And then after that, you think that this patient need replacement, not repair. Okay, when we say repair, we mean that the valve is intact, and we will do something on the leaflet, but we don't replace the valve. So when we say replace, we're replacing the whole valve. So when we do valvular replacement or valve replacement, we can have choice. Either we can give the patient mechanical valve, or we can give the patient bioprosthetic valve. Okay, so what is the type of mechanical valve that we can have? So we can have a single tilting disc. You don't need to remember the name, so the name is not so important. The most important is the mechanism. So you have a single tilting disc. So single tilting disc is very rare nowadays. Hardly ever people put it in. We also have ball and cage. So we don't no longer put ball and cage valve nowadays, but because the ball and cage is very it lasts very long, so we can still see once in a while patient with ball and cage valve. And lastly is bileaflet. So bileaflet is the most common. Almost, I would say, about 99% of patients that you see, they will have a bileaflet mechanical valve. Okay, so this is the most important for you to remember, the bileaflet mechanical valve. So this is example of the bileaflet mechanical valve. So salient point about bileaflet mechanical valve, they have two major orifice on the side. So when it open, it have two major orifice on the side and one minor orifice in the middle. So this have impact in terms of pressure recovery, which I will explain a bit later. This is a single tilting disc. You have one major and one minor orifice. And lastly, this is a ball and cage. So ball and cage is just go through around the ball. Okay, when it opens. So when it opens, the ball actually go up. So what about bioprosthetic valve? How can we classify bioprosthetic valves? So the way we classify it is, usually it's either two. It can be either porcine or pericardial. Okay, most of the bioprosthetic valve, it is either porcine or pericardial. So if you notice, all the valve will have a number. So the number is the valve diameter, and also a type. Okay, for example, I give you example. So we have Medtronic mosaic valve. Okay, so that is a porcine valve. So maybe we have another type of valve called a Carpentier Edwards. So that is a pericardial valve. Because there is a lot of names, so I don't advise you to remember the name. So just remember that there is porcine and there is also pericardial. We also have now TAVR valve. So this is very important because now TAVR has explodes, and the indication has expanded to even low risk. Okay, so the TAVR valve is usually a pericardial valve. So this I show you what I mean by stented. So this is a stented valve. You can see that there is a ring around the leaflet. So this is a stented valve. So this is stainless. So you can see that there is no ring. So there is no metal thing around the valve. And lastly, this is a valve that is also with a root. Okay, so imagine someone that have aortic dissection or aortic aneurysm, and you want to replace the root with the valve. So this is that. There's the composite of root and valve. So example is a Medtronic freestyle valve. Okay, so this is the type of bioprosthetic valve. You can either have porcine or pericardial. Okay, or you can have stented or stainless. Okay, and also in a select patient, you will have a valve with also the root. So that those with aortic root problem. Okay, so that's how you remember mechanical and bioprosthetic valve. So just tips on valve replacement. The problem with valve replacement, regardless whether you give the patient mechanical valve or you give the patient bioprosthetic valve, you give the patient survival penalty. You know, that is not good. Doesn't matter if it's tissues versus mechanical, mitral versus aortic, single versus double. So at 10 years, okay, 20% of your patient is already dead if you give them replacement. That's why I always say, in mitral valve, especially in mitral space, if your patient valve can be repaired, you repair the valve. Okay, don't replace in mitral valve. If you can repair it, repair, because the survival penalty here. What is the reason you have this problem? Okay, so in mechanical valve, you know that the patient needs warfarin, so there has a risk of bleeding. Okay, what are the problem with mechanical valve is there is also a problem of valve thrombosis. Okay, so that is another problem with mechanical valve. Now, in terms of bioprosthetic valve, this valve, the Achilles heel and the one that is the main problem of bioprosthetic valve is structural valve degeneration. So when I say structural valve degeneration, what do I mean? What I mean is the valve can become calcified. Okay, it can have pannus. Pannus is overgrowth of tissues. The leaflet can tear or it become flare. So that is structural valve degeneration. That is a problem with bioprosthetic valve. So whenever you implant bioprosthetic valve, there is an understanding that in 10 years, the patient will have another reoperation to replace because of structural valve degeneration. That does not happen with metallic valve. So with mechanical valve, there is less structural valve deterioration, okay, but there is more thrombus, bleeding, and also patient prosthetic mismatch. So that is a problem with the mechanical valve. The bioprosthetic valve, the main problem is structural valve deterioration. Okay, remember, whenever you see a report that says calcification, pannus, flail, tear, even dehiscence, sometimes it is because of structural valve deterioration. Remember that even in bioprosthetic valve, we have thrombus, and we know this because of studies after studies have shown that the bioprosthetic valve have thrombus in about 15% of the population. So the study that I have done here in Mayo Clinic have also shown the same, that thrombus account about 10 to 15% of prosthetic valve dysfunction, even in bioprosthetic valve. That's why even in bioprosthetic valve, we give anticoagulation after surgery. Some people give it for 6 months. Some people give it for 1 year. You know, some people even ask for lifelong anticoagulation in bioprosthetic valve. So this is a pivotal study in JAMA. This is published in 2014, looking at survival and long-term outcomes following bioprosthetic. You can see that it doesn't matter if it's bioprosthetic or if it's mechanical valve. At 10 years, you have 20 years survival penalty. So mechanical survival is the same as bioprosthetic. Okay. What about if you ask me, or what about if it's AVR versus MVR, or MVR versus DVR, tissue versus mechanical is exactly the same. You can see here, AVR tissue versus mechanical is the same. MVR tissue versus mechanical is the same. Even if you do both, so dual valve replacement, it is the same survival penalty. So let's talk about mechanical valve, okay? So the commonest mechanical valve that is used is a bileaflet valve, okay, about 99% of the time. The problem with bileaflet valve is that a small bileaflet valve, when I say small, okay, usually the size of valve begin with 19 millimeter. So 19, 21, 23, 25, 27. So 19 and 21 millimeter valve for bileaflet valve is prone to pressure recovery and patient prosthetic mismatch. What is pressure recovery? I will talk about it in a few slides. Patient prosthetic mismatch is a valve that is too small for the patient. Okay, so if for example, if you put a valve that is 19 millimeter or 21 millimeter, even though the valve is opening and closing completely okay, completely normally. Now the problem is that valve is still very small for a certain type of patient. So if your patient have a big body, that valve is too small. So therefore, you will have an elevated gradient across the valve, even though the valve is working normally. And this is actually detrimental to the patient. Okay, so we know that the patient have poorer outcome in terms of survival and also functional outcome if they have patient prosthetic mismatch. So beware of putting in a small valve in the patient, especially 19 and 21 millimeter valve. This patient prosthetic mismatch and also patient prosthetic mismatch also happen in bioprosthetic valve, not just mechanical valve. There is burden of lifelong anticoagulation, bleeding, and thrombus can be catastrophic. For some reason, thrombus outcome is worse for mechanical compared to bioprosthetic valve. Okay, if thrombus happen to both, once thrombus happen, it is worse in terms of mechanical compared to bioprosthetic valve. The main advantage of metallic valve is, of course, its durability, okay, which is the Achilles heel. So the structural valve degeneration is an Achilles heel of bioprosthetic valve. In mechanical valve, when you see regurgitation, be it physiological or pathological, it is usually paravalvular. Very rarely, it is transvalvular. What about bioprosthetic valve? Okay, bioprosthetic valve, otherwise known as xenograft. Why is xeno? Because it comes from other animals. Okay, remember that it is either pericardial or porcine. Whenever you talk about bioprosthetic, pericardial or porcine. So the valve is usually stented. It can be either porcine or pericardial. The standard valve is usually used in root replacement or inclusion. So the problem with bioprosthetic valve is structural valve degeneration, okay? Calcification, tear, flail, and pannus. Thrombus is also increasingly recognized for the past 10 years. And other types of bioprosthetic valves are, okay, so the most common is xenograft, meaning that the valve from other animal, okay? But this is the rare one, okay? I just wanted to familiarize you with the term. You also have homograph. So what is homo? So homo is human. Okay, so graft from cadaveric human, homograph. So for example, okay, I give you an example. So there is a procedure that is called a Ross procedure. So what is Ross procedure? So someone with problem with the aortic valve, okay. So what happened is we transected the aortic valve and also the aortic root, we take it out, okay. And then we take the pulmonary root and the pulmonary valve and bring that to the aortic position. So now the pulmonary root and valve is no longer there. So what we do, we put a homograph. So we put a cadaveric root and also valve to replace that pulmonary valve that we use in the aortic position. Okay, that is homograph, graft from cadaveric human. So when it's homo, it is from human. What about auto? So auto meaning that the valve comes from your own self. Okay, remember in Ross procedure just now, I told you that they take out the aortic root and aortic valve, but they put the patient's own pulmonary valve and pulmonary root into the aortic position. So that is autograft. You use your own tissue. Okay, so that is homograph and also autograph. So that is basically the difference between mechanical and bioprosthetic valve. I hope you can remember that. So now we're going to go into the importance of echo measurement. Okay, what is the importance of echo measurement? So in terms, we know that whatever go into the aortic valve is the same that goes out. So the stroke volume going into the aortic valve is the same that the stroke volume going out the aortic valve. So that is our continuity equation. Okay, so pi r squared times LVOT VTI is equal to effective orifice area times aortic valve VTI. So whatever goes in must come out. So if you look at the formula, so this is the formula, LVOT VTI times LVOT surface area equal to effective orifice area times aortic valve VTI. So pi r squared is LVOT surface area. So we rearrange the equation, pi r squared times LVOT VTI over aortic valve VTI is the effective orifice area. So this is how we do effective orifice area, be it on a native valve or prosthetic valve. Remember, I tell you, okay, the most important thing whenever you are dealing with aortic valve is the VTI, the LVOT VTI and aortic valve VTI. Why is that so important? Because we only have one chance to do it while the patient is in the echo lab. Okay, if let's say the patient is already outside of the echo lab, you cannot adjust this measurement. You can adjust the LVOT diameter, but you cannot adjust this measurement. So that is very important in both prosthetic and also native valve. Now, the effective orifice area, if you divide to patient body surface area, you got an effective orifice area index. Right? Now, in native valve, this is very important. So in native valve, you need to look at this. Even at the beginning of assessing the patient. This is different for assessing prosthetic valve. So in assessing prosthetic valve, my advice to you is don't take into account effective orifice area or effective orifice area index early, meaning that there is a time where in prosthetic valve, you look at effective orifice area, it might make you worry or it might make you think that the valve is dysfunction when it is not. Okay, so don't start with effective orifice area when assessing the aortic valve, and assessing prosthetic valve, okay? Remember, when the VTI is wrong, all your calculation is wrong, okay? So the most important thing in terms of prosthetic valve, okay, the most important thing is your dimensionless index, okay? So you start with that rather than start with your effective orifice area. So what is dimensionless index? It is LVOT VTI over aortic valve VTI. That is very crucial that you get that thing correct, okay? So in our studies as well, the one that is most predictive of obstruction is dimensionless index, okay? In ASE guideline, the parameters or the threshold is less than 0.25. Now, next, we make sure that the LVOT diameter measurement is correct. Remember, when we do 2D echo measurement, we almost always underestimate the LVOT diameter. Therefore, we overestimate the severity, right? Measure in zoom view parasternal long axis, measure in AIM systole. In native valve, the measurement is between the right coronary cusp leaflet and the commissure between the left coronary cusp and non-coronary cusp. So the leaflet tips and commissure. And the measurement is from inner to inner wall. The only way to ensure correct aortic VTI is measurement doing by multiple windows. Okay, so you have to go right parasternal as well. So make sure the LVOT Doppler contour is smooth and there is also no spectral broadening. So this is what I mean by measurement. So you measurement from inner edge to inner edge. So from this is the right coronary cusp, okay? So this is a commissure between the NCC and LCC. So you should see a leaflet tips here and you shouldn't see a leaflet tip there, okay? So this is a proper measurement. And remember, we almost always underestimate the LVOT diameter. RCC, commissure between the NCC and LCC, okay? In terms of measuring the LVOT VTI, so remember that this is not good. If you see, you can hardly see a black inside here, and this white thing between here and here is what we call a spectral broadening. We don't want to see that. So the better shape of LVOT VTI is like this. You can see quite a lot of black here, and there's not so much spectral broadening. Another tip that I wanted to tell you is try to ensure that you can see a closing click here. Okay, closing click, this line. So when you see this line, most probably you are in a correct space when you're measuring LVOT VTI. Okay, so that's how you measure it. So I hope you understand that. Okay, now whenever we assess prosthetic aortic valve or even prosthetic mitral valve, we realize that the patient have a problem when there is increase in velocity or increase in gradient. Okay, so the abnormal velocity that I take as my threshold is more than 3 meters per second. So if I say any prosthetic valve, aortic valve, have velocity that is more than 3 meters per second, then I start to get worried. Okay, so what is the cause of this elevated gradient across prosthetic valve? Number one is true obstruction, meaning that yes, there is abnormality of the valve. There is something obstructing the valve. Okay. Number two is patient prosthetic mismatch. The valve is too small for the patient. Okay. Number three is high flow. Say patient have hyperthyroid, patient is anemic, patient have fistula. Number three is patient have aortic regurgitation, concomitant regurgitation, also can cause high gradient across the valve. And also last one is pressure recovery. Okay. So what is pressure recovery? Now, pressure recovery is a phenomenon when you measure a gradient using echo, and the gradient is higher than a gradient that you use using catheter. Okay, what is pressure recovery? One more time, I tell you, it is a gradient that you measure during echocardiogram that is higher than the gradient that you measure in catheter. Okay. So it is one of the cause of high gradient across prosthetic aortic valve. And when does pressure recovery happen? So in terms of prosthetic valve, it happens in two situations. Number one, it happens in patients with small bileaflet mechanical valve. It happens because the echo is measuring the velocity of the central orifice, and the catheter is measuring the velocity when the slower two lateral orifice has converged distally. Okay, that's one. Number two, if you have a small ascending aorta that is less than 3 centimeters. The echo is measuring the velocity when it is turbulence just distal to the valve, so the gradient is higher. The catheter is measuring the velocity when the flow has become laminar in the ascending aorta. Okay, so the mean gradient has become lower, right? So there is a two situation where you see pressure recovery. When we say there is significant pressure recovery in the context of prosthetic aortic valve, what it means is that the mean gradient when we use echo is significantly higher than mean gradient when we measure it by catheter distally. Okay. In this situation, the catheter is a better indicator of a hemodynamic burden faced by the patient, right? So I show you, okay, because I know that this can be confusing, okay, we can discuss again at the end, but I show you with a picture, okay? So let's say in normal situation, this is your heart, okay? Let's say you measure that inside your left ventricle, if you have a catheter here, the mean gradient is, let's say, 140 millimeter mercury, okay? Now, if you measure with echo, the echo measurement will measure just distal to the valve, okay, just distal to the valve, be it a prosthetic or native valve. Now, we look at the echo mean gradient, you see that the mean gradient from echocardiogram is 40 millimeter mercury, okay, meaning that if you put a measurement just right here, you can see the measurement of the gradient is 140 minus 40, meaning that this is 100 millimeter mercury. So there is a drop of 40 millimeter of mercury pressure here. When you go here to here, because the potential energy has been converted into kinetic energy, you have the drop of 40 millimeter mercury. So that is what you measure here. Okay. Now, in a patient that doesn't have pressure recovery, the catheter will measure distally here. The catheter measurement should also be the same, 40 millimeter mercury in terms of the gradient. Okay, so this should be 100 and this also 100. The drop should be 40 and also 40. So this is a normal patient. Okay, you measure here with echo, you measure there with catheter, it doesn't make a difference. All right. Now, what happened in a small bileafle mechanical valve? So you start with a potential energy of 140 millimeter mercury inside the left ventricle. However, you have a bileafle valve here, small one. You measure with echocardiogram just distal to the bileafle valve. Okay, the echo will measure the velocity from the central orifice that is smaller. Whenever the orifice is smaller, the velocity is higher. Now, when velocity is higher, there is more pressure loss in terms of the kinetic energy and also heat. So, for example, if you measure there, the potential energy might be 90. Therefore, the gradient or the difference is 50 millimeter mercury. So this is 140, this is 90. So that is pressure drop of 50 millimeter mercury. Okay. However, when you measure distally using catheter in the aorta, the velocity on the lateral side that is slower has now converged. So the slower velocity on the lateral side that is now slower has converged. Therefore, the pressure has recovered. So if you measure here 90 millimeter mercury, it have recovered here to 100. So therefore, with catheter, you measure 40 millimeter mercury. Okay, so this is what I mean by pressure recovery. You measure by catheter, the mean gradient is 50. But you measure by echo, the mean gradient is 50. But you measure by catheter, the mean gradient is 40. That means that there is 10 millimeter mercury of potential energy that is recovered from here to here. Okay, in this situation, the one that is better reflected hemodynamic burden feel by patient is the catheter mean gradient. So that is one situation. So what is the other situation? So the other situation is, of course, patient with small aorta. So imagine this patient with a small aorta that is less than 3 centimeter. So this is 140 millimeter mercury inside the left ventricle. We measure just distal to the valve. All right. So we get a mean gradient of 50. So let's say there is a pressure drop of 90 millimeter mercury. Okay, you got the mean gradient of 50. Now, however, this is turbulence. The smaller the aortic valve here, the more laminar it becomes. The more laminar it becomes, the more the kinetic energy is recovered to potential energy. Okay, so in this situation, for example, just for teaching purposes, if we measure, suddenly we measure that here has become 100. Okay, so what happened? So what happened is that you have a pressure drop of 50 millimeter mercury here. The pressure drop is because of change into kinetic and energy is also hit. However, some of the kinetic energy is recovered here because the turbulence flow has become more laminar, so you recovered 10 millimeter mercury of your energy. Again, the cat is lower than the echo, right? So this is pressure recovery, right? So other than that, most people we will expect that the mean gradient measured by echo is the same as mean gradient measured by catheter. All right, except in someone with small bileafle mechanical valve or someone with small aorta less than 3 centimeter. I hardly ever see people with aorta that is less than 3 centimeter in adult. So I hope you understand that. Okay, that is pressure recovery. So mean PG at echo should be the same with mean PG at cath. However, in small bileafle valve, there is one minor and two major orifice. Echo measure the minor orifice when the pressure drop is bigger. More distally, the minor and major flow converge and you have recovery of the pressure so that the pressure drop is lower. So another situation is you have a small aorta, the turbulent flow at the flow convergence. So the turbulent flow here becomes significantly more laminar here. So significant kinetic energy is converted to potential energy. Thus, the catheter measure less pressure drop. In this situation, the catheter measure 40 and the echo measure 50 millimeter mercury. So this is just showing you what happened in the bileafle valve. Just distal to the orifice, transthoracic echo cannot differentiate whether it is from the minor or major orifice. So they just show you the major orifice here. However, distally, you can see the lateral orifice have now merged with the minor orifice, and the catheter will measure here. So that is what echo measure. This is what catheter measure. All right. So that is pressure recovery. What about patient prosthetic mismatch? So this concept was introduced by Rahimtullah in 1978. So this is another differential diagnosis of high gradient across valve. In essence, it is when the valve is too small to sustain adequate cardiac output in relation to patient body size. It's more common in aortic valve position and in smaller size valve. It affects all types of valve, mechanical, bioprosthetic, or even TAVR valve, but to a lesser extent. What is the threshold? So the threshold for aortic valve is less than 0.85 centimeter squared per meter squared for ppm and less than 0.6 centimeter squared per meter squared for severe ppm. For mitral valve, it is slightly bigger. It is at less than 1.2 centimeter squared per meter squared. So what is our general approach to prosthetic valve, high gradient across prosthetic valve? In general, the approach between the mechanical and bioprosthetic valve is the same. Okay, the most important thing is to remember this is the difference between mechanical and bioprosthetic valve. Okay, I just show you all the different. Okay, the different number one, the most common valve dysfunction for mechanical is thrombosis and bleeding. The most common dysfunction for bioprosthetic is structural valve degeneration. So for mechanical, it is thrombosis. For bioprosthetic valve, is structural valve degeneration. In mechanical, thrombosis can be fatal. In fact, thrombosis in mechanical valve is worse than biological valve. In bioprosthetic, thrombosis happen usually in about 15% of bioprosthetic aortic valve dysfunction. All right. In mechanical valve, structural valve deterioration, it is much less common compared to biological valve. In bioprosthetic valve, patient prosthetic mismatch does occur, but it is less common than mechanical valve. In patient with mechanical, ppm is commoner, especially in a small size valve. In bioprosthetic, if you look at the valve, there is increase in gradient, and you see calcified leaflet with thickening and reduced mobility, suspect structural valve degeneration. For bioprosthetic valve thrombosis, valve thrombosis, suspect when the gradient increases more than 50% from the baseline, you have thickening without calcification and also restricted motion of the leaflet. Right. So when we assess the valve, okay, let's say when we look at the echocardiogram, what we want to do is, number one, we want to see what is the type of dysfunction. Okay, what are we dealing with? Are we dealing with obstruction? Is it a true obstruction? Are we dealing with regurgitation? Are we dealing with mixed obstruction and regurgitation? Are we dealing with patient prosthetic mismatch? Okay, so whenever we look at the elevated gradient across the valve, we want to answer, is this obstruction? Is it regurgitation? Is it mixed? Or is it patient prosthetic mismatch? Okay, and that is what the algorithm will help you to decide. Once you know what is the type of dysfunction, you want to know what is the reason the patient have dysfunction. So one is type, another one is mechanism. Is it structural valve degeneration? So this one, you have to look at the leaflet. So if leaflet is thickened and calcified and you see panels, so that is structural valve degeneration. Or is it bioprosthetic valve thrombosis? So for example, the valve is thickened without calcification. Is it infective endocarditis? Remember, infective endocarditis can also cause obstruction or stenosis. Or is it patient prosthetic mismatch? So we want to decide what is the type of dysfunction, and then we want to decide what is the mechanism of prosthetic valve dysfunction. So how do we approach in terms of the type? Okay, so what we do is, whenever we see a prosthetic valve, we look how does it appear in our eyes. Okay, now if the peak velocity across the aortic valve is less than 3 meters per second, and you don't see from the color any moderate or severe aortic regurgitation, then you are dealing with a normal valve. You can stop there. Okay, the peak velocity is less than 3 meters per second. I'm talking about aortic valve, and there is no AR, then you can stop there. Now, if you see the peak velocity is less than 3, but you see moderate or severe AR, then of course it is moderate and severe AR because you can see it. Now, what if the velocity is more than 3 meters per second? Okay, now if the velocity is more than 3 meters per second, American Society of Echocardiography has published a guideline for you to decide whether this is obstruction, whether this is patient prosthetic mismatch, or whether this is just high flow across the valve. Okay, so look at this. This is the algorithm. Number one, you look at the peak velocity. Okay, if the peak velocity more than 3 meters per second, second, you look at dimensionless index. This is how important the dimensionless index is. After that, you look at the Doppler across the aortic valve. Look at the shape of the Doppler. A triangular shape is good. A parabolic shape suggests that something is wrong. Then you integrate. Give you an example. Let's say the peak velocity is more than 3 meters per second, but your dimensionless index is 0.32, which is normal. And your acceleration time is 70 milliseconds and triangular, also normal. Okay, so you see that, oh, now everything seems to be normal. Then you calculate your effective orifice area, and you calculate your effective orifice area index. It is 0.7 centimeters squared per meter squared. And you know that is small for the valve. So that is patient prosthetic mismatch. Okay, I will give you an example later. So give you some tips. In assessment of prosthetic valve, try not to look at aortic valve area first at this stage. Okay, this often can be small and be misleading. Look at stage down here, not here. And always ensure that the measurement of LVOT VTI and aortic valve VTI is correct. Right? So just wanted to give you the example. So this is an example of a normal aortic valve. This is an example of obstructed prosthetic aortic valve. So what's the difference that you can see? So you can see both the velocity is more than 3 meters per second. However, look at the contour of a Doppler across a normal valve. It is triangular. Triangular. Look at the contour across the obstructing aortic valve. It is parabolic. Okay. What's more? What is other different? Look at the acceleration time. The acceleration time is the time from the aortic opening click to the maximum velocity. This is 73 milliseconds, less than 100. That is normal. This is more than 100, 140 milliseconds. That is abnormal. That is also important. Look at the ratio of LVOT VTI to aortic valve VTI. Okay, if it's less than 0.25, it is very subjective of obstruction. Okay, so the study that we did here shows that the most important parameter for obstruction is dimensionless index. After that, it is acceleration time. And what we find is acceleration time and over ejection time is useless for the diagnosis of obstruction. Okay, so that is awaiting publication. I will update you next time. So I give you cases now. Okay, so case one is St. Jude Bioprosthetic porcine. So I told you bioprosthetic can either be porcine or pericardial. So this is a St. Jude brand name bioprosthetic porcine valve. The size is 25 millimeters. So that is the type of valve there, right? So this is a parasternal long axis view. So this one, what we look whether the valve is opening normally. We look whether there's any calcification or thickening. We look on the color flow whether there is no obvious regurgitation. Okay, so this patient, let me just tell you, there is no obvious regurgitation. So that's the aortic valve there. So this is a short axis of the aortic valve. Now the reason that the parameter is so important is because often in 2D we cannot see very clearly. So if we look at the short axis view here, there's nothing significant. Okay, we can't really see properly here, right? All right. So we measure the LVOT diameter. So the LVOT diameter for this prosthetic valve is 2.33 centimeter. Okay, that is good enough. Usually most of the LVOT diameter is more than 2. This is measuring the LVOT VTI. Okay, so this is fairly good in my opinion. Okay, however, there's quite a lot of this white thing from here to here. I would prefer that there is more black. Okay, and I also prefer that we can see an closing click line here. Okay, however, be it as it may, we accept this LVOT VTI just for the sake of teaching. This is the aortic valve Doppler across the aortic valve. So what made me not worried? Look at the peak velocity. The peak velocity is way less than 3 meters per second. So I have a peak velocity that is less than 3. I have valve that appear good. There is no significant aortic regurgitation. So usually I stop there. I don't get headache. That is a normal valve. Okay. If you need further reassurance, you can see that the acceleration time is way less than 157. From the start to the peak is only 57. So that's okay. So that is normal. So that is 57 there. Okay, so what is summary? So this patient have normal valve. The color Doppler looks okay. There is no significant regurgitation. The peak velocity is less than 3. Usually I stop there. This is a normal functioning valve. However, if you want reassurance, the dimensionless index is way above 0.25, which is 0.43. And the acceleration time is very short, 57.7 milliseconds. And if you look at the effective orifice area, look at the index is 1.01. Okay, so if you look at this first, you might say, oh my God, that looks too small. Okay, so don't look at that first when you assess prosthetic valve. Look at the top first. Okay, so this is just a normal valve. Let's look at our second case. So our second case is a Medtronic freestyle valve. This is a bioprosthetic. Remember, it can be either porcine or pericardial. So this is porcine. It is 27 millimeter. So Medtronic freestyle is actually a composite of also root and valve. Okay, when you see a Medtronic freestyle, it's a root and also a valve. So 27 millimeter. The assessment is the same. Okay, again, not good window. So this is a parasternal long axis view. Again, I'm sorry, I don't put a color, but just assume that the color flow is normal. There is no significant regurgitation. Again, LVOT diameter is 2.15 centimeter. A short axis, you can't really see anything. Okay, that's why Doppler is very important when assess aortic valve. Remember, in transthoracic, aortic valve is very difficult to see. Also, same with transesophageal echocardiogram. This is a LVOT VTI, and that is the aortic valve. Okay, again, look at the Doppler, look at the acceleration time. It is 71.6. That's very good. Okay, less than 100, right? So this is 71.6. So this is short acceleration time. And we calculate our dimensionless index. This patient dimensionless index is also above 0.25. You can see that the maximum velocity is way less than 3. It is 1.57 meter per second. So that's normal. So this is another patient with a normal valve, this time stanless. However, assuming that the color Doppler across aortic valve didn't show any abnormalities, the fact that the peak velocity is less than 3 meters per second is enough to conclude that this is a normal valve. So this patient dimensionless index is 0.67. So this is a normal valve again. Okay, the EOA is 3.26. The index is 1.55. Now, let's look at this one. This is a pericardial prosthesis. Okay, it is a Carpentier-Edwards. So I show you that. That's an example of Carpentier-Edwards. It is 25 millimeter. Okay, this is a parasternal long axis view, okay, of the aortic valve. Right, let's look at the next one. So we just zoom at the parasternal long axis view of that aortic valve. So see whether there's any obvious thickening, vegetation, calcification, any regurgitation. This is short axis view. We can hardly see anything in short axis view of the aortic valve here. So this is LVOT VTI. So this shows you the importance of measuring LVOT VTI. And this is the aortic valve. Okay. Now this one is a bit more borderline. You can see that the acceleration time is 95 milliseconds. So it's almost 100, but not yet 100. Okay. What about the velocity? So you can see the velocity in this situation, the max velocity is 3.07. So whenever velocity is more than 3, we need to explain what is the reason the velocity is more than 3 meters per second. Look at the dimensionless index. The LVOT VTI over aortic VTI is 0.26. Okay, so where do you think this patient valve situated in? Why the velocity is more than 3? So we need to plug in into the algorithm, right? So that patient have patient prosthetic mismatch. That is the reason the velocity is more than 3. I will show you a little bit later. The patient valve looks normal. However, the peak velocity is more than 3, and we have to explain this. We make sure that the LVOT VTI and the aortic valve VTI is correctly measured. The dimensionless index is 0.26. The acceleration time is 95 milliseconds, less than 100. In this situation, we look at the effective orifice area and we calculate the effective orifice area index. It is 0.54 centimeters squared. So this is patient prosthetic mismatch. So the velocity is high because the valve is too small for the patient. Okay. Now, how do I know that? Look at the algorithm. I start with a velocity that is more than 3 meters per second. However, my dimensionless index is 0.26, so it is at the middle. My acceleration time is less than 100, so it is there. That is my acceleration time. Okay. Now look, this is a normal valve, right? So now we need to do effective orifice area index. So our patient effective area index is less than 0.85. It is 0.65. So this is patient prosthetic mismatch. So let's look at our fourth case. So this is a porcine valve. It is a Hancock valve. So the name is not important. It is 21 millimeter bioprosthetic valve. Again, parasternal long axis view. Right. So this is the short axis view. You can see a turbulence across the aortic valve. You can see mild aortic regurgitation. So usually mild aortic regurgitation, I don't worry so much. Okay, usually it is not significant. This is a LVOT diameter. Again, this is the LVOT VTI. The dimensionless index is 0.28. Again, in the middle, right? 0.30 above is normal, less than 0.25 is abnormal. Look at the aortic valve. The acceleration time is 83.3 milliseconds. But look at the velocity. The velocity is very high, 4.5 meters per second. Is it very high? It still can this still be a normal valve with a velocity of 4.5? Okay. Yes, it can still be a normal valve. Just wanted to tell you, don't be fooled by the velocity. You still need to look at the contour of the Doppler. So this Doppler looks triangular, and the acceleration time is also fast. So looking at this, I also suspected that the aortic valve is working normally. So this is another patient prosthetic mismatch, okay? From 2D view, you can see that the valve looks normal. There is no obvious thickening. There is no calcification. The color only show mild regurgitation. So moderate and severe, I worry. Mild, I usually don't worry about it. However, the peak velocity is 4.5. And you have to explain why the peak velocity is 4.5. So you look at the dimensional index, it is 0.28. When you look at the Doppler profile, it is triangular, which is normal. And acceleration time is short, 83.3 milliseconds. And lastly, when we do the effective orifice area index, it is 0.58 centimeters squared per meter squared. So this is severe patient prosthetic mismatch. Okay, patient prosthetic mismatch is not a benign condition. It reduces severe survival and reduces functional class. Okay, there is a time when even in patient with a normal valve and patient prosthetic mismatch, they are symptomatic. We operate on them and we replace the valve. Okay, so this patient have velocity that is more than 3 meters per second. The DVI is 0.26. The acceleration time is 70 milliseconds. This is a normal valve. Okay. However, when we index, it is less than 0.85. So this is another case of patient prosthetic mismatch. What about this one, case 5? So this is a Carpentier-Edwards, also a pericardial valve. So this is a 25 millimeter. So this is parasternal long axis view of the aortic valve. So this is a Doppler across the valve. There is no regurgitation, but we can see a turbulent flow across the aortic valve. It can be normal, it can be abnormal. So this, we look at short axis view of the aortic valve. We can see calcification here of the aortic valve. Okay. So we're still not sure whether what is the type of obstruction or what is the type of dysfunction. So we look and we do our LVOT VTI. So we took our continuous wave Doppler. So this is right parasternal view, right? Look at how parabolic is this Doppler. It's very parabolic. Look at acceleration time, it's way above 100, it's 120.6 millisecond, okay? Now, DVI is 0.21, way less than 0.25. Even looking at this, we know that something is wrong. So this is a true obstruction. Once we say that this is true obstruction, we know the type. Then we try to say what is mechanism. Is this structural valve degeneration? Is this bioprosthetic valve thrombosis, or is it infective endocarditis? That have to do from the appearance on echo. You can do CT, you can do MRI, you can even do pathology in surgery. So what is the summary for this patient? So looking at the 2D image, the prosthetic valve leaflet is thickened and bright. Okay, if it's thickened and not bright, it might be thrombosis. But if it's thickened and calcified, it is structural valve deterioration. You can see that the peak velocity is 3. This need to be explained. Look at DVI, it is less than 0.25, it is 0.21. So this looks like a true obstruction. Look at acceleration time, it is prolonged at 120.6 milliseconds. Regardless of our effective orifice area or effective orifice area index, we already know that this is true obstruction. Furthermore, because of the classification, we don't only know the type of obstruction, dysfunction, we also know the mechanism of dysfunction. If you look at our algorithm, the peak velocity is more than 3. We wanted to explain that. The DVI is way less than 0.25, and the acceleration time is more than 100. This is a true prosthetic valve stenosis. Why the obstruction? Because we can see that it is calcified. So most likely this is structural valve degeneration. Okay, this is likely structural valve degeneration. So this is case number 6, Medtronic freestyle again. So root and valve, it is a porcine valve, bioprosthetic. This is looking at the parasternal long axis view, right? So looking at the valve, again, there is no obvious regurgitation. Okay, there is turbulent flow across the aortic valve. That's okay. Right, so we need to see the velocity, whether it's abnormal or not. Okay, this is short axis view. Again, it is not revealing. This is the LVOT VTI. DVI is 0.17. Okay, we already worried when the dimensionless index is so low like that. We can see that the acceleration time is 153.3. So we know that this is a true obstruction. The max is 4.0 meter per second. So what a summary for this patient. So when you look at this patient valve, you can see that the valve is thickened, but there is no obvious calcification. So whenever you see the gradient that is increased from the baseline more than 50%, and you can see that the valve is thickened, so that means that this is most likely bioprosthetic valve thrombosis. So from 2D images, we can see some thickening of the leaflets. Looking at the Doppler of the aortic valve, it is more than 3 meters per second. So even if the valve looks fine, explanation is needed for that high velocity. The DVI is 0.17, and the acceleration time is very long at 153.2 milliseconds. So from the algorithm, we know the patient have obstruction. Now, because of the thickening without classification, most likely the mechanism is bioprosthetic valve thrombosis. However, we can often diagnose obstruction, but we cannot tell the mechanism. So in this situation, we can only know from pathology, okay? And the treatment for bioprosthetic valve thrombosis is very simple. It is anticoagulation with warfarin. So this patient, again, velocity is more than 3. However, DVI is less than 0.25 and acceleration time is more than 100. That is true valvular stenosis. Look at case 7. So I have gone through bioprosthetic valve. Just now I wanted to show you a mechanical valve. This is a top hat 25 millimeter bileafle mechanical valve. In aortic position, mechanical and bioprosthetic valve, the assessment is the same. Okay, so this is a short axis of bioprosthetic view. Sometimes in mechanical valve, we can see 2 lines that is closing and opening in the short axis view. Not all the time. So this is a long axis view. Again, nothing revealing in the long axis view here. Okay, this is the LVOT VTI, and that is the aortic valve VTI. You can see that the Vmax is 2.85. So what do I tell you? If the peak velocity is less than 3, if the color doesn't show significant regurgitation, usually I'll stop at that. I know that this is a normal valve. Okay, the acceleration time is short. So the 2D images is very poor. However, in this situation, Doppler can be reassuring. Whenever I see that peak velocity across the aortic valve is less than 3 meters per second, unless the leaflet is obviously restricted, I am happy to say that this is a normally functioning valve. Furthermore, the acceleration time is short and the DVI is 0.52. Okay, so that is a normal mechanical valve. Look at case 8. So we have gone through bioprosthetic, we have gone to mechanical. Let's look at transcatheter. So transcatheter valve, mainly two types of valve, either sapien valve or core valve. A sapien valve, as you can see, so all sapien valve is shorter. The profile is shorter. When you look at the core valve, the profile is long. Okay, long, short. Okay, the assessment is the same. So this is a transcatheter sapiens 3 valve, size is 26 millimeter. So sapiens, okay, usually in core valve, you can see that the edge of the valve is lower, okay, because it is a longer profile. So this is shorter. So one thing that I wanted to tell you about transcatheter valve, the hemodynamic of transcatheter valve is extremely good. Usually the peak velocity, the gradient is very, very low across transcatheter valve. Again, we zoom view of the transcatheter valve. So in general, approach to transcatheter valve dysfunction is exactly the same as bioprosthetic valve. Okay, in terms of structural valve degeneration, we are not quite sure whether TAVR bioprosthetic is better than surgical, but we think that it is most likely better because TAVR valve have better hemodynamics than surgical valve. Thrombosis also happen in TAVR valve. In fact, the incidence of subclinical thrombosis is quite high, it's about 30%. Sometimes when you do CT scan for transcatheter valve, it is even better to look at subclinical thrombus. So they have this acronym for you to look at subclinical thrombosis in CT scan. You look at two things. One is HALT, H-A-R-L-T, HALT. That is an hypoattenuating leaflet thickening. And another one is REM, R-E-L-M, restricted leaflet motion. So the combination of REM and HALT suggests TAVR valve thrombosis. When estimating the effective orifice area of Edward Sapiens valve by echo, it is recommended to use the LVOT diameter and velocity measured immediately proximal to the stent. Okay, this example, how to measure LVOT diameter in patient with sapien valve. Okay, so that is the proper measurement of sapien valve. So you see the edge of the stent just proximal to the edge of the stent. So that is the measurement of sapien valve. So this is case number 9. This is a core valve. Okay, you can see the core valve have longer profile. So you can see that the core valve actually extend way into the left ventricle. In fact, I have seen a case in which the patient have subaortic obstruction. Okay, subaortic membrane, and they use core valve to overcome that problem. Okay, not a leaflet, but subaortic because the core valve is so long. I just wanted to show you how does core valve look. Okay. Right, so that's core valve. So with core valve, usually you measure it. All right, so I just wanted to tell you the reason I show you this is for you to familiarize the transcatheter valve, because this will become more and more frequent. So this is the core valve. Okay, the way to assess is same as other valve. All right. However, you can see the core valve is long. So where do you measure the LVOT diameter of the core valve? You have to measure the LVOT diameter inside the stent. So we have looked where the leaflet is, and you try to measure the LVOT diameter there. So if it is not possible, you have to see the LVOT diameter prior to the procedure. So this is different from sapien valve, in which you measure the LVOT diameter at the edge of the stent. So this is the stent. This is your to measure the LVOT diameter for sapiens valve. Okay. In terms of the algorithm, we use the same algorithm. All right. So we almost finished. So I wanted to tell you again the summary of prosthetic valve. Remember, can be either mechanical or bioprosthetic. Mechanical, 99% of the time is bileaflet valve. Bioprosthetic, it can either be porcine or pericardial. All right. TAVR valve is usually a pericardial valve. In terms of assessment, both are the same. Okay. You need to know what is the type of dysfunction. This is based on algorithm. Is this obstruction? Is this regurgitation? Is this mixed? Is this patient prosthetic mismatch? Remember the concept of pressure recovery that I've already teach you. After you know the type of dysfunction, look at the echo, determine the mechanism of dysfunction. Is this structural valve degeneration? Is this bioprosthetic valve thrombosis or even mechanical valve thrombosis? Is this infective endocarditis or is this patient prosthetic mismatch? Type of dysfunction, mechanism of dysfunction. Okay. Now, I want to touch on some weakness on the current algorithm. Okay. So I am been working in prosthetic valve for the past 1 year here in Mayo Clinic. So we have finished a manuscript in which we try to improve on the assessment of current mechanical valve. So number one, if you look at the algorithm, the appearance of the valve, if you look at the algorithm, it's all number. So the appearance of the valve is not explicitly included in the algorithm. So when we did the study, we see that the algorithm is not as accurate as we want it to be. So the algorithm is actually it is not weak, but it is not so good either. Okay. So what we do in our study is we propose and we include the appearance of valve in our algorithm. And if you look at the algorithm, there is no place for mix. So you can either have stenosis or regurgitation. We don't have both in the algorithm. So in the new algorithm that we propose, there is a column for mixed stenosis and regurgitation. And the algorithm accuracy needs validation. So that's what I've been doing. We have validated the algorithm and it is not accurate. So what we have done is we have propose a new algorithm to increase the accuracy of the current ASE algorithm. So when we have finished the manuscript and published the paper, I will update you what is the new algorithm all about. So I won't tell you now, we will just wait for the paper. And we have also done at the middle of looking at the mitral and also a tricuspid space. So that will be, I think, a bit later. I will also update to you a bit later. All right. So that is the end of our assessment of bioprosthetic prosthetic valve or prosthetic aortic valve for today. I will do the mechanical valve and I will show you a little bit of picture of thrombosis and degeneration or calcification in the next session. So I think this is it for today. So if there is any question, really thank you for joining me. If there is any question, please feel free to ask.